All right, welcome back. This video is going to be right in your wheelhouse. In this section, we're going to go over soft contact lens and more. Okay, so in this video, we get to talk about soft lenses. So this is everybody's favorite topic that we get to talk about in contact lens, right? We're also going to talk about how we stabilize toric contact lenses. We're going to talk about LARS, which is going to be the most clinically relevant thing that we're going to probably talk about in contact lens. We're going to use that every day in practice seeing contact lens patients, right? And then we're going to finish up talking about accommodation, vergence, and the magnification differences between wearing contacts and wearing glasses. So good, let's dive into the text. So if you guys look in your text, the first thing we want to talk about is soft contact lenses. Just kind of the big picture, remember soft contact lenses drape the cornea. So that means that there's no lacrimal lens or tear lens power. So you guys want to highlight that in your text. Lacrimal lens power is always plano. You want to circle that. So what does that mean? What rule does not apply to soft contacts? That's exactly right. SAM-FAP does not apply. So you want to write that out in really big letters. SAM-FAP does not apply to soft contacts. Great job, guys. Let's talk about toric contact lenses or astigmatism lenses, how we stabilize those. So a couple different methods that we have listed here in the text. Prism ballasting is going to be base down prism incorporated into the contact lens, so it kind of weighs the contact lens down, keeps it from rotating. Peri-ballasting is going to be a base down incorporated in the contact lens outside the optical zone. Okay, so you want to circle that in your text, outside the optical zone. Dynamic stabilization is going to be really a concept where you're thinning the superior and inferior portions of your contact lens, and that helps center that because of the eyelid pressure, helps center that contact lens and keeps it from rotating. That's going to be your dynamic stabilization. Now, eccentric lenticulation, which is a hard word to say, right? That's going to be a combination of peri-ballasting and dynamic stabilization, right? So you have both of those in one design. That's eccentric lenticulation. Now, truncation is just where you're going to simply cut off the bottom portion of the contact lens so it sets on the eye, on the lower eyelid to minimize rotation. It's kind of more of a GP contact lens thing, but it's listed here in your text as well. Now, let's talk about LARS, right? So LARS is going to be something we're going to use all the time, right? I know you guys know LARS. I just want to hit a couple of high points here to make sure you guys dominate these questions whenever you're going forward in boards, right? So the first thing is you want to remember that LARS is going to be from the clinician's perspective or from the patient's perspective. That's exactly right. It's the clinician's perspective. So you want to write that in your text, right? It's from our perspective, how we're looking at the patient. So write in from clinician's perspective. The next thing to know is that do we talk about LARS from the 6 o'clock position or the 12 o'clock position? Yeah, it's going to be the 6 o'clock position, right? We're going to talk about rotating left or right from the bottom of the contact lens whenever we're doing our LARS calculations. So you want to write in from clinician's perspective, 6 o'clock position, right? Now, we all know left add, right subtract. That's the good part, it's the easy part. I know you guys know that from clinic, right? I think the harder part where it comes from stretching this into a question would be, what about clockwise and counterclockwise rotation, right? So let's simplify that. Let's look in your text. You guys see if base, apex, meridian rotates clockwise, right? That's going to be add to the axis or left add. Do me a favor, highlight or circle the 1L in clockwise, right? So clockwise has an L in it, left add. Good. Now let's go to the second one. If the base apex meridian rotates counterclockwise, you're going to subtract, right subtract. Look at counter and circle that R, right? So counterclockwise, counter is going to be right subtract, right? So those are two things that always confused me whenever I was a student. I was looking at it there and I saw, okay, clockwise has got an L, counter's got an R, L and R, boom, I've got it. Haven't missed it since. So hopefully that'll help you guys have the same domination. All right, let's go and work example 5.32. You fit a soft toric contact lens in the right eye with a prescription of +1, -2 axis 150. On the slit lamp examination, you note the contact lens rotates 10 degrees counterclockwise with blink. What new axis should be ordered to compensate for this rotation? All right, let's take that to the whiteboard. So to solve example 5.32, right, whenever we look at our picture, we know this is going to be the right eye. The contact lens is going to be rotating 10 degrees to the right. So we know with LARS, right, we're going to right subtract. Now the key point I want to bring up here is that remember whenever you're doing LARS, you always add or subtract from the spectacle RX, right? From their spectacle RX. So whenever we do that, we're going to put axis 150 here, right? And we're going to subtract 10 degrees from that. So our final contact lens that we're going to order, right, is going to be +1 -2 axis 140, and that's to compensate for this consistent 10 degrees rotation. Awesome, guys, let's keep on going. So now we want to talk about some general fitting guidelines for soft contact lenses. And the first thing we want to talk about is what kind of diameter do we want to have to fit a patient in a soft contact lens? And the way to answer that is that you want to have at least 1.5 millimeters of extension of the soft contact lens beyond the Limbus 360, right? So how that breaks down into a way it could come up in like an optics type question, right? Or a boards type question would be soft lens diameter for a patient based on their HVID, right? So you would take their HVID that would be given to you in the problem, their horizontal visible iris diameter, right? And what you're going to do is you're going to want 1.5 millimeters of coverage all the way around. So what you're going to do is you're just going to add simply 3 millimeters to their HVID, and that's going to give you your soft lens diameter, right? So an example, if we had an HVID of 11.5, right? So let's just throw some numbers out here. So we have an HVID of 11.5, right? What would be the soft lens diameter we'd want to fit that patient in, right? Well, that would just be, you take 11.5 plus 3, right? And you're going to get 14.5 millimeters, right? Would be the ideal diameter to fit this patient in. Now let's talk about gas permeability and soft contact lens materials. So the key thing that I want you guys to take home is there's a box here that talks about in general oxygen permeability depends strongly on water content, right? And so what I want to talk about is comparing hydrogel contacts to silicone hydrogel contacts, right? So if we have a hydrogel contact lens and we increase the water content in a hydrogel contact lens, what does that do to the oxygen content getting to the cornea? That's going to increase O2 to the cornea, right? It's going to increase oxygen to the cornea. And you guys can highlight that in your text. High water content is high permeability or higher decay, right? So if you increase water in a hydrogel, that's going to increase oxygen to the cornea. Now in a silicone hydrogel, right, if you increase water content, right, remember that silicone doesn't like water, right? And so silicone transports oxygen more quickly than water. So if you increase the water content in a silicone hydrogel contact lens, what you're actually going to do is you're going to decrease the oxygen to the cornea, right? So you can highlight that in your text. High water content is going to equal a lower silicone content, right? So you're going to lower your permeability of oxygen to your cornea. So you're going to actually lower the decay of that contact. Now, is that something we think about clinically? Not always, because silicone hydrogels, even ones that have a higher water content, are still going to have a decay, 90 plus. So we're still going to get a lot of oxygen to the cornea, but technically that is a true statement, right? If we increase water content of silicone hydrogel, it's going to decrease oxygen permeability to the cornea. Now let's talk about rigidity of a contact lens, and really rigidity breaks down to the stiffness of a contact lens. So in my book, I wrote right above rigidity, just wrote in stiffness of a contact lens, to just kind of simplify that in my mind. And you guys can also highlight that in the text if those of you guys that love highlighting stuff, describes the stiffness of a material, right? Now it's dependent on a couple of factors. So I kind of drew up this in my book. I have this out to the side of these notes just because I'm a very visual person, so I like to have arrows because it helps me kind of visualize what's going on. This is also in the text, so you could just highlight this in your text. If we increase the modulus of a lens, right? Increase the modulus of elasticity of a lens, right? What's that going to do? That's going to increase the stiffness of that contact lens, right? It's going to make that contact lens more rigid. If we increase the thickness of a contact lens, right, that's also going to increase the stiffness of that contact lens. Now, if we increase the water content of a contact lens, right, what that's going to do is that's actually going to decrease the stiffness of that contact lens. So for me, this kind of summarizes that paragraph in your notes into a real easy visual point that you guys can look at and then go on to the next topic, right? So increase modulus, increase stiffness, increase thickness, increases your stiffness, and then the key one here is increase water content. That's going to decrease the stiffness of that contact lens. All right, so let's finish up this session talking about accommodation, vergence, and magnification effects, comparing glasses to contacts. Now, before we get into this, one of the things that's really important to know, right, is that whenever somebody's wearing a pair of contacts, whether they are a hyperope or a myope, and they read something at 40 centimeters, right, it doesn't make a difference whether they're a hyperope or a myope. If they're in contacts and they're reading at 40 centimeters, they're going to have to accommodate, assuming they're fully corrected, right, they're going to have to accommodate 2.5 diopters to read whatever it is at 40 centimeters. So with contacts, it doesn't matter whether you're a hyperope or a myope, you're going to accommodate the same to whatever stimulus is in front of you if it's at the same distance. And that's really super important. So highlight that in your text. All patients will accommodate equally to a stimulus when wearing contacts. So what we're going to talk about, right, is what about a hyperope wearing glasses compared to a hyperope wearing contacts, and a myope wearing glasses compared to a myope wearing contacts. Very good. Let's look at the text. So hyperopes accommodate less with contacts than they will wearing glasses, right? And myopes are going to accommodate more with contacts than they will wearing glasses. Now, the optics behind this is just going to be effective or downstream vergence, right? And you can get into it and do the math if you would like, but I don't know if the optics is necessarily important moving forward. I think understanding the concepts and how it's maybe going to apply for you clinically, I think is where we want to hit on. So the concept you've got down, clinically where this may come up is you may have a patient that you are fitting, let's say a myopic patient, right? And they've been wearing glasses and now you're going to fit them in contacts, right? Well, they may come back in their 1 or 2 week post-op or post-fitting visit, right? And they may actually say, hey, you know, I've noticed a little bit of some eye strain like reading and studying since I got in my contacts, right? And you're going to go, why is that? That's because you have to accommodate a little bit more in contacts if you're a myope than you do in your glasses, right? And some of you guys may be that patient. Some of you guys may have seen some patients like this recently, right? I'm that person, right? You know, I wore contacts a lot in high school, college, and in optometry school. I really didn't have a lot of problem in high school and college, but once I got to my first year of optometry school, and you guys know how much studying we do. Like I got married that summer before we got in optometry school, and I felt bad because like I never saw my wife. It's like I literally was at the library. Like I'd go home for dinner and then go to the library till like midnight, and you guys know what that's like, right? We're glad we're through that. So I was that patient. So with my contacts in, I was starting to actually get a lot of eye strain whenever I was reading, right? And I never really kind of figured it out, and we didn't notice at that point in time. I went to a professor and I was telling them what was going on, and I explained, hey, in my glasses, I'm okay, but in my contacts, I feel like I get a lot of headaches around my eyes. And so I'm exactly this patient, right? So what can you do? A couple of things, right? You can look at doing like a multifocal contact lens, right? Or you could also maybe think about doing like a low-powered reading pair of glasses, and that's what I would do whenever I was studying in my contacts, right? So this is something that, you know, yeah, maybe it'll be on boards, but this is something really clinically right here, right? So kind of circle that, put a clinical point to the next to that, because that may be something if you haven't seen, you're going to come across at some point in time whenever you get down the road. All right, let's get back to some information here. So whenever we talk about magnification differences, hyperopes, whenever you think about them wearing glasses compared to contacts, right? Remember, plus lenses magnify the world. So if we were talking about magnification, hyperopes are going to have increased retinal image size wearing glasses compared to contacts, right? So look in your text, hyperopes are going to have a smaller retinal image size with contacts, right? Myopes are going to have a larger retinal image size with contacts, and that's because whenever we wear our minus lenses, it's going to minify the image. So whenever we take that away, right, and we wear our contacts, we're now going to see the world as the way it's supposed to be, right? And it's going to be a larger image. Very good. Last point here is vergence at the bottom of the page, right? This kind of ties into the prisms aspect that we talked about. What is a plus lens? Think of it as like 2 prisms base to base, right? And think of a minus lens as being like 2 prisms apex to apex, right? So whenever a myope is wearing their contacts, right, they're going to have to converge less than they would if they're wearing their glasses, right? Because whenever they're wearing their glasses and they start to converge, right, they're going to be looking inside the optical center of their glasses, and they're going to get induced base out prism, right? And so they're going to have to converge more wearing their glasses. Now a myope, on the other hand, right, whenever I'm wearing my glasses and I read, I get some induced base in prism, right, with my glasses, and so I don't have to converge as much. So whenever I wear my contacts, right, I'm going to have to converge more. So you want to highlight that. So myopes converge more with contacts compared to spectacles because of less induced base in prism. All right, guys, we've got through contact lens. You guys have dominated this material. Go dominate the quiz, and we'll see you on the next video.